Okay, so back to really homeostasis is what we're talking about here, and keeping that balance and equilibrium, like you told me. So, however you like to describe it or define it, it really has to give us a balance, right? And not just a balance overall, but a range of balance within range. Because if you go outside of homeostasis, then you're looking at disease or pathophysiology. So that's really important. So these are the parts of what's called a feedback mechanism. I'm going to call this feedback. You're going to see this again. And you could have positive feedback or you could have negative feedback. But I'm going to give you a little hint that most of our feedback mechanisms are negative. Like the ones we mentioned already are all negative. In fact, there's only one positive feedback mechanism that we're going to talk about in this class, and that's childbirth. And I'll explain what that means. So, really, what that's saying is, what that is saying is that the outcome is going to be enhanced until it goes out of control almost. Negative feedback creates an output like shivering or sweating, and that will be stopped when it gets out of homeostatic range. So if your body temperature needs to be raised, it'll raise the body temperature within homeostatic range. It won't go above it, and it'll turn off. And that's the negative part, turning off the initial output. And positive does the opposite. It enhances the initial output and keeps doing it without a shutoff mechanism, which is appropriate for something like childbirth. And blood clotting is another one. I think it is appropriate, but it does cause problems. Okay. And there's a couple of positive feedbacks within the female reproductive system, which we'll talk about that later on. Okay. So this is a term I really want you to know, a receptor. This is the detection, and it's a change, like a change in blood pressure or change in body temperature or a change in your mental status, from being calm to having fear, right? Because that has a physical effect. So the receptor is always nervous tissue, always nervous tissue. Um, there is exceptions. I shouldn't say always because your pancreas has cells that act as receptors. So like the pancreas doesn't need the brain to change your glucose levels, is what I'm saying. But you'll learn that when we get there. But receptors normally nervous tissue, and nervous tissue are made up of most of our sensory receptors, which you'll see. So the stimulus is not just a stimulus; it's a change. Right? And your body has to react to that change. That's a big deal. Like temperature, sensed in the nerve tissues, the thermoreceptors in the integument. So the receptor is going to send an input to a place called control center. Now the control center, again, is almost always a part of the brain. Usually the part of the brain that we don't think with. We're going to talk a lot about the brain later on, so I'm not going to take up your time now. So the brain is the control center. It's going to decide to send a signal, or an output, I should say. And it sends an output, usually definitely through nervous tissue, but it could cause an output by the nervous system. And that's a quick response. You're going to learn what synapses are and how fast the nervous system works. Remember, whenever you hear nervous system, think fast electrical changes, outputs, causing other structures like muscle, glands, and the heart to actually do more work or do less work sometimes too when it's a negative feedback, like things like blood pressure, really controlled by the nervous system. Now, again, I'm not going to go into that too deep yet. The slower version is the endocrine response. Remember, these are hormones. Remember what I said about endocrine? It secretes its substances or chemical messengers directly into the blood, as opposed to exocrine, which is into ducts or out of the body. So hormones, I'm talking about hormones regulating It can regulate blood pressure. Hormones can regulate blood pressure. Hormones, of course, you're going to learn a lot about calcium regulating hormones. So first you have a stimulus, it's just the change. Then you have the receptor that senses the change and sends a signal input to the control center, which most of the time is part of the brain. You're going to hear places like one of my favorite homeostatic parts of the brain. Listen up for this one. My favorite homeostatic part of the brain is the hypothalamus. So the hypothalamus is a deep part of your brain, the most homeostatic. It's really the master of our endocrine system too. I don't care what they say about the pituitary. I mean, I love the pituitary too, but without the hypothalamus, pituitary could be useless. Very important. So we got to get that oxygenated blood to the brain, number one. And another place is a little bit lower in the brain stem called the medulla oblongata. So this is not so much hormonal, but this is more basic things like heart rate, blood pressure, lowering heart rate, and increasing heart rate, increasing blood pressure, or decreasing blood pressure, and respiratory as well. Breath rate up, breath rate down, controlled in areas within the brain, specifically the medulla oblongata. So hypothalamus is more about hormones like growth hormone, thyroid hormone, and your reproductive hormones. Even has an effect on cortisol being released from the adrenal cortex. So the control centers are big. It's not always these two, but most of the time. And it's worth us talking about right now. So down here, you have number 3 is the effector. I think this is the one that we have the hardest time understanding. So this is where the output is going to. Let's use heart rate, right? Let's say heart rate. Let's talk about this, an effector. Let me just see what's on the next slide before I get in your face. Yeah, that's just the cascade, but let's talk about this whole situation here. Let's use an example. Anybody have a good example of something we need to control? Like heart rate, what's one of your favorites? How you feeling, Claudia? You okay? How's your bladder? Okay for 2 hours so far?
I was going to mention urination.
I'm not surprised on that. Yeah, urination. Okay. What could I put to urination with a feedback mechanism? Okay. First of all, your water balance, right, has a lot to do with your blood pressure, like how much water you have in your blood. So your blood volume. So the kidney has something to do with that, and how much urine you're going to hold on to, or how much urine is going to be excreted out into the public sewer system. So here's what happens. Let's say, and I'm giving you another hint about the human body. Listen to this one. Our body is much more about raising our blood pressure than it is about lowering it. It's probably why a lot of people have hypertension, higher blood pressure than they should, because and my best guess is, let's say 150,000 years ago, we weren't worried about like buying MH Connect or if, my newspaper was delivered today, or if my wife had picked up the right milk. We were 150,000 years ago, we were worried about losing blood if the lion used us as lunch, right? First of all, we're stressed out about, we're running away from the lion. We're stressed out about that. Then if he gets us, again, we're going to be lunch. We're going to lose a lot of blood or we're going to be dead. But let's say we lose a lot of blood. So if we do lose a lot of blood, we're decreasing our blood volume. Everybody, does that make sense? If we get bit by a shark, or if we get eaten by a bear, bit by a bear, we're going to lose blood. Our body's very sensitive to losing blood, because if we lose blood, we're losing oxygen. And if we don't have oxygen, we can't make ATP in our cells, right? So our blood pressure needs to be maintained at a higher level most of the time, okay? So, and that's the reason why. There's maybe only one mechanism that really lowers our blood pressure, and I'll tell you about that when we get to endocrine. So let's say our blood pressure drops for some other reason, but it goes below homeostatic range. Now, our blood pressure on the average, textbook average is like 120 systolic over 80 diastolic. So let's say our blood pressure goes down to like 85 over 40. That's pretty bad. That's almost anaphylactic shock. Like if somebody's allergic to peanuts, their blood pressure is going to drop. And that's what that means. Your blood vessels vasodilate and it drops you. So your cardiac output is never going to get to your brain. If you don't have oxygen in your brain, your hypothalamus and your medulla oblongata are not going to work correctly, and you're not going to be able to breathe. You'll be put on a ventilator. You know, that's what happens now with the COVID, or it happens if somebody has ALS. So you're very concerned about dropping of blood pressure. So if your blood pressure drops that low, your body goes into what's called sympathetic stimulation, which is fight or flight, really, and it increases your retention of water. So your kidney is going to stop making urine to be urinated out. It's going to build up in the blood. You're going to retain the sodium. You're going to retain the water. All the hormones, all the nervous system responses to the kidney are going to do everything they can to hold on water. You're going to learn about this antidiuretic hormone, about aldosterone, how that reabsorbs sodium and water back into the body. Remember this, wherever sodium goes, remember that Na+, water follows it. It's osmotic pressure, which we'll talk about and you'll talk about it when you talk about the cell membrane. So you're going to be holding on to more urine, or more water, I should say. It's not urine. Urine is what goes out. So the more fluid we have in our blood, the higher our blood pressure. So your body's going to try to compensate for that. So also your nervous system, which is the part of it's called sympathetic nervous system, is good, and it's released from the medulla oblongata to accelerate your heart rate, make your heart beat faster so we can get blood to the brain, and squeeze your peripheral blood vessels like your arteries to increase your blood pressure. So it does that homeostatically, but it doesn't want to overcorrect it where it goes to, let's say, what's a high blood pressure number? Remember, the average is like 120 over 80. So if your blood pressure doesn't go up to 180 over 100, it has to cut off that mechanism, and the brain has to cut off that output. Are you with me?
Yeah.
So here's the hard part. So now the effector is the target for the nervous system or the endocrine to make that change. So remember before we talked about shivering, right? The effector, when my body temperature went down when I was out with the dog, was my skeletal muscles to shiver. So the effector was the skeletal muscle in that feedback mechanism, or in that mechanism. What is the effector in this low blood pressure scenario?
The heart.
There's two, actually. The heart, number one. Very good. Cardiac muscle. And in AMP2, you'll learn that there's actually pacemakers within the heart that increases your heart rate. Very good. The heart. Excellent. The heart to beat harder, stronger, get more pressure into the vessels. And the vessels themselves are also effectors. Because learn this, when our blood pressure needs to be raised, the sympathetic nervous system, fight or flight, will send out a signal to the blood vessels to constrict. So that's called vasoconstriction. So vasoconstriction increases your blood pressure systemically. But it doesn't want to increase it so much that it's going to go too high, right? Anybody have any questions about that? That's kind of tough, right?
So what's the other?
The other would, what do you think? What do you think the other would be?
The brain,
Well, we're talking about urine though. We're talking, you mentioned water.
kidneys.
The kidneys, right? The kidneys would be the other effector. So all the output would go to the kidneys, and the kidney can release hormones. Kidneys and the hormones that are released target the kidney. So in effect, the kidney is the effector. Very good. So if you have to go, right? But you don't want to overcorrect, and that's what the negative feedback part comes in. That's really important that you understand that. Now, let's talk about childbirth, because that's a positive feedback mechanism, right? That's a positive feedback. So childbirth, right? Claudia, you could tell us here. The first thing that happens during labor, right? Now we're in labor, because this is when all the stuff happens. you have your uterus. Everybody know what the uterus is? You'll learn the uterus at the end of the semester, but it's a big muscular structure. It's smooth muscle though. It's not skeletal muscle, and it's definitely not cardiac muscle. So the uterus begins to stretch when 40 weeks is up. There's a lot of other hormones involved, that actually take care of this, like the cortisol is actually released from the placenta, and it's a timing thing. Again, that's a miracle. I can't even explain the timing of these things. But anyway, it's ready. The baby's ready to come out. So the head hopefully is pressing on the cervix, which is the opening of the uterus, and it's stretching it. Everybody agree? Like a head, a head coming out, pressing into your uterus, trying to get out of a closed uterus, really. So the stretch is the stimulus. That's the change in the muscle. The receptors are stretch receptors in the cervix. Once the cervix stretches, like they say dilation, or they say, 10 centimeter dilation or whatever. So it starts to dilate. So when it dilates, it has to stretch because it's muscle tissue mostly. There's epithelial tissue too, mucous membranes, but it also has a stretch in the muscle. So the receptor is a stretch receptor, a mechanical receptor that sends a signal to, where's my favorite place in the brain? Homeostatic.
Hypothalamus.
Right to the hypothalamus. You believe that? So the signal goes to the hypothalamus, which is the control center. Hypothalamus says, okay, well, uterus is stretching. This is rare. Well, this poor woman, she only had 400 viable eggs in her whole lifetime. Let's get to work. So the hypothalamus will send a signal to the posterior pituitary to release a hormone. Anybody know what that hormone is called? Begins with an O, ends with a tocin. Oxytocin, right, oxytocin. So oxytocin is released from the posterior pituitary gland. And where do you think it's targeting? To squeeze that uterus to get little Claudia out, or Claudio. What has to squeeze the baby out, or the newborn out?
The uterus.
Uterus muscle, very good. So the effector is what in this feedback mechanism? You just said it.
The uterus?
The uterus, Renee, very good. Very good. Congratulations. So now this is a positive feedback, the only positive feedback we're going to talk about now. So every time that cervix stretches, the hypothalamus is going to send out more oxytocin. And guess what? It's not going to stop. It's not going to stop until the baby comes out and then the placenta comes out. Then it's going to stop, but it's going to keep sending that oxytocin over and over and over. Never, it doesn't care about homeostasis at this point. This is worse than getting chased by the lion. We got to get this baby out. 100 years ago, most of the people were dying from childbirth. Now it's routine, right? Because they didn't know what to do with this. So really, your body's still evolutionarily trying to get that baby out by increasing the pressure on the uterus, by squeezing it. So the smooth muscle contracts in the uterus, and it continues to happen until everything is out. Make sense? Make sense to all you people?
Yeah.
Yes.
Yeah, me
Yes.
too.
Yes.
So
Yes.
that's the positive feedback. So everything else is negative feedback, like blood pressure, body temperature, heart rate, blood glucose, calcium. Okay, all that, calcium levels, which we're going to talk a lot about next time. So those are pretty much all the steps that you have to go through to have these feedback mechanisms and control homeostasis. So let's see, what's next is basically just kind of talking about what we just said, right? You have a stimulus, which I like to say is a change in whatever the system is, and this case is temperature or stretch, like pretty much what we just talked about. The receptor is usually nervous tissue, like for temperature, it could be in the skin. And that input, the receptor sends the input to the control center, which is usually the brain, and sometimes an endocrine gland like the pancreas. And then sends an output. And the output goes to the effector, like the heart. You guys said that really well. Or the blood vessels to constrict and increase blood pressure. All right, very important. And then homeostasis is restored, but it still doesn't tell me here Like what were we talking about before? Low blood pressure, right? If it's too low, it doesn't want to move this dial too high. And that's why the negative feedback has to come in. And the negative feedback is a control center job. The control center has to know when to shut the output off. And that's negative feedback. Positive feedback, it can go off the charts. It can go down here. Positive feedback, like in the childbirth. Blood clotting works the same way. Certain, like during ovulation with estrogen, it's a positive feedback, which you'll see later. So everybody pretty clear about this?
Yeah.
Okay. So it's a range.
Yeah.
It's a range. There's no set point, although your pH and your body temperature are pretty consistent at 98.6. Like, let me just tell you, like you already told me about the pH. I'm sorry, about the body temperature is 98.6 and 37 degrees Celsius. But something like pH, which is the percent of hydrogen that makes your blood either acid or alkaline, you kind of understand that? And we don't want a lot of alkaline. I'm sorry, we don't want a lot of acid. Our body's much more sensitive to acid, but we also don't want a lot of alkaline. Like there's a pH scale that goes from 0 to 7 to 14. And in the laboratory, anything less than 7 is acid on the pH scale. And greater than 7 is base or alkaline. But the pH of blood is got to be a little basic. So remember this for later. I'm going to talk about this a lot. The pH of blood, here's another memorization for you. pH of blood should be at 7.4. Now you may have an argument, well, there's a range, Dr. Finizio, 7.35 to 7.45. That's true. But the range is completely compensatory between the kidneys and the lungs. So we want that number to be here. If it's any higher than this, you have acidosis. If it's any lower than this, I'm sorry, did I say acidosis? Any higher than this, 7.4, it's alkalosis. Any lower than 7.4, it's acidosis in blood. Laboratory 7 is neutral. That's my point. So there's going to be variances. It's going to go up. It's going to go down as long as it stays in this range. And every mechanism, every system has a range. It's really important in order to get that homeostasis. Oh, breastfeeding is another one. Lactation. And the hypothalamus is big on this one too, releasing prolactin from the anterior pituitary. So blood clotting, and the one we're going to talk about most is labor for positive feedbacks. And the climactic event for childbirth is, having the baby come out, right? Right, then that's the climactic event, and then followed by the placenta too. Don't forget that, the umbilicus and all that. Looks like the baby's holding the placenta in that picture. Beautiful drawing. Blood clotting I'm a little worried about though. The positive feedback of blood clotting can cause injury to our blood vessels. So it's appropriate when there's injury, like the lion chasing us, but not when we're getting stressed out and vasoconstricting and eating too much Popeyes. Then we got a problem, or a genetic problem with clotting. Breastfeeding's good, again, that's basically prolactin, which you'll learn about in endocrine and reproduction. So again, in this case, this, it's funny, this is also oxytocin, but I'd rather say prolactin, and I'll tell you why. Again, I forgot that McGraw-Hill uses this one as a example. So a lot of schools are getting phone calls now. Schools are closing tomorrow because of the snow. So here, in this particular case, this stimulus is the suckling of the baby onto the nipple, the breast. The receptor, of course, in this case is my friend, the hypothalamus. And the hypothalamus releases oxytocin, in this case too, just like it does for the uterus. But oxytocin only releases it's released to the breast tissue, to the alveolar glands or areolar glands, and it ejects milk. So oxytocin is all about milk ejection. So that it'll keep coming as long as the baby is suckling. You'll continue to get oxytocin release, which is also involved in the release of breast milk. Prolactin is more important because that's making breast milk. That's more, and we'll learn about that when we do endocrine. So now we learned two things about oxytocin. So oxytocin is an interesting chemical release from the posterior pituitary. It has multiple functions. One of them is, of course, during labor. The other one is during breastfeeding for ejection of milk, positive feedback on both. But anybody know another function of oxytocin in the brain? And it has something to do with mother and child too. Speak out if you want. It's kind of interesting.
Contractions?
Contractions? Yeah, that's pretty much the uterus contraction that we already mentioned. So no, it's something more psychological actually. And
The bonding.
it's the bonding, Renee. Dr. Wright. You're right. You're correct, right, Dr. Wright? Yeah. So oxytocin has builds a connection between, of course, between mother and child. But what if you're a wolf and you're out in the woods and your mother's dead? Then you might have an oxytocin sharing event with a polar bear or a bear, right? It depends on whoever you're bonding with at that time, like a surrogate, they call that. So oxytocin has that bonding effect. I like it, Renee, very good. And that could be a problem with oxytocin, could be a problem in some cultures, right? If you have too much oxytocin, let's say you live in one area, like you're a zebra, right? You're a zebra. You live in your area where you've been raised by zebras. Okay, the occasional hippopotamus will raise a baby zebra, but you're releasing that oxytocin for a long time. So it gives you a sense of community, a sense of belonging. So if you go out of that zebra neighborhood and you go into the alligator neighborhood, your oxytocin may cause what's called xenophobia, where you're afraid of anything that's not like you. That's a problem, right? That's a problem for xenophobia is something that our brain has to correct that. We have parts of our brain, which you're going to learn in the cerebral cortex, the prefrontal cortex, that makes our cognitive decisions. And we say, oh, okay, that I may not be an alligator. I'm not an alligator. I don't hang out with alligators, but the alligator is not much different than me. So you have to make that decision. It's not an excuse, right? So that's oxytocin is a very interesting chemical. It's released as a neurotransmitter too. It's not just a hormone. And we'll talk a lot about that when we get to neuro and endocrine. Where are we going next here? Some more questions about this to go through. Again, you don't have to print all this. This is just for your own knowledge. So this is homeostatic characteristics and dynamic, of course, because you have to be able to change and respond. Remember, a lot of nervous system stuff. Control center again is the nervous system mostly. The endocrine is really more output, but every once in a while, like the pancreas, it has its own. Pituitary gland, not so much. So here they are, the receptor, the control center, and the effector. Mostly regulated through negative feedback. All right, your homeostasis, to keep it into that homeostatic range. So say homeostasis a lot, because that's what we're going to use a lot. Even when we get into bone, believe it or not, it's going to be really important that we know all about those things. So here's some numbers. Your body temperature. I think you guys are good with this nowadays, right? Every time you fill out a form and go somewhere to a doctor, they take your temperature anywhere. They take your temperature. Blood glucose has a range, 80 to 100. Blood pressure, again, 90 to 100, 120 is systolic, and 60 to 80 diastolic. We'll talk more about blood pressure when we do the autonomic nervous system, which is the sympathetic versus parasympathetic. Remember, sympathetic nervous system is fight or flight. Parasympathetic is rest and digest, if you can remember that for later. Okay, so about testing samples within the population. Okay, and this is normal for most of these people. Some people are out of range. Of course, not everybody's exactly the same. There's always anomalies where somebody's glucose is okay at 150 milligrams per deciliter. But again, this is based on all the population. So I think this blood pressure is a little bit high, 120 over 80. 120 is good, but I think the 80 should be lower in the population. But like I told you before, our body's more about raising blood pressure than it is lowering it, which is true. So here's diabetes. I like to talk about diabetes because it tells you a lot about feedback mechanisms, mostly the endocrine system, diabetes. Like if you're afraid of having diabetes, or if you do have diabetes, you're going to wind up in an endocrinologist's office more than you would in a neurologist, unless the diabetes is so bad it affects your nervous system, which could cause neuropathies. Like a lot of diabetics have neuropathies, which is like numbness in the feet or numbness in the fingers, and your blood vessels actually die because there's too much glucose in them, destroyed. High glucose levels in your blood is destructive. Again, nowadays, our diet has changed over the last 150,000 years. Remember the lion chasing me? He was having me for lunch. I don't know what I was having for lunch, but it probably wasn't Popeyes 150,000 years ago. So now there's probably too much glucose in our diet. I mean, I don't want to vilify glucose because you need carbohydrates. I'm not a big fan of the keto diet, although it does help people lose weight. I'm not a fan of it because you need glucose. I'm not talking about glucose where you go to, 7-Eleven and you buy a Coca-Cola that Claudia could stand in, but just, a balance, right? And a homeostatic amount, if you will. So we want to regulate our blood glucose. And sometimes it's just bad luck. Sometimes, we have what's called diabetes mellitus type 1, diabetes type 1. Anybody know what that is? Like, what's the problem in diabetics who are type 1 diabetes, which most of the time they get it when they're very young? What can't they make? What can't their pancreas make?
Insulin?
They can't make insulin, right? Yeah, that type 1 is they just can't make insulin. So it doesn't matter, how much glucose is never going to be brought into the cells. It's never going to reach the mitochondria. So the glucose just stays in the blood and is extremely destructive. And if you have no glucose getting into your cells, of course, you have to rely on fats and proteins to make ATP when you're supposed to be using glucose, and you're not going to live very long. So imagine how exciting it was back at the turn of the century when doctor walked into a hospital with an injection or a needle syringe full of insulin and saved people's lives. So we still, and believe it or not, we still don't know how to treat this other than giving them insulin. I shouldn't say we don't know how to treat it. We don't know how to cure it. All right. So diabetes mellitus type 1, for the most part, is autoimmune, means our own, and this is the best I could tell you, is autoimmune, meaning that our own immune system is destroying our beta cells in our pancreas that make that make insulin. So autoimmune, or of course, this is genetic. So this is passed down to family. So you can be tested for, the possibility of you having diabetes type 1 as a child, or your child having diabetes type 1. And it's getting a little better that way by DNA mapping, right? So then there's diabetes type 2, diabetes mellitus. Mellitus means sweet. So back in, again, 100 years ago, they probably used to taste the urine to see if it was sweet, and they would call it diabetes mellitus. So type 2 is you can make insulin, you just can't use it. And this is more typically older people, overweight with metabolic problems like obesity or heart-related conditions, bad diets, bad lifestyle, going to Popeyes every day, going to Dairy Queen every other day, too much blood glucose, where your receptors for insulin say, all right, that's enough. We can't get enough insulin out. We can't use these receptors anymore. You become resistant to insulin, and then you have no glucose going into your cells. So you're diabetic type 2. So the blood glucose is what it's all about. And the blood glucose is actually the control center, is the pancreas itself. This is one of those cases. So of course, in normal circumstances, when the blood glucose is high, it's going to release insulin. The glucose will go into the cells or make glycogen, like I mentioned before, through anabolic reaction. So insulin is anabolic. The other thing that could happen is you have too low blood glucose, hypoglycemia. And in that case, you're not going to release insulin. Your pancreas is going to release another hormone called glucagon. And glucagon will take the glucose from the liver and the muscle, actually from the glycogen, break down glycogen, catabolize it, and increase your blood glucose to its homeostatic range. So it has to be homeostatic, like we said, 80 to 110, or 90 is a good number, is homeostatic. And that's a really important thing, blood glucose, when we go through these classes. So, of course, diagnosis, yeah, we got to find out. We got to take a blood test for diabetes. And then this test, like, again, we're not going to talk about diabetes too much now, but there's A1C and fasting glucose tests. Some of you probably heard of all of these. But it's all about homeostasis and staying within that range. Okay. So again, it just goes on about things like that. Homeostatic control, I don't know why they're mentioning this now, because this is more nervous system thing. SSRIs, about neurotransmitters. So I don't want to get too into neurotransmitters right now, especially serotonin. This is imaging here. This is pretty cool, right? X-ray. And then this is CT scan, which is really X-ray, just very computerized X-ray. Tomography is being able to slice everything up. Very cool. And then MRI is magnetic. So these two use ionizing radiation, like will mess up your electrons, actually. They'll mess with your DNA. And if you get too many X-rays, again, I know some of you may be pre-radiology techs, so you're going to be very careful about how much radiation you're around if you're an X-ray tech or you're a CT scan tech. Of course, you're never in the room when these gamma rays, these ionizing radiation is being released. MRI is much better because it's magnetic, changes those protons. This is a proton, like that acid thing, because remember, it's very polar. This is an ultrasound or sonography, very cool, doesn't damage the DNA, non-ionizing. It's a real safe way to see little Finizio there as he's being born, or she. This is why I mentioned this before, where you inject dye and you can take an X-ray and actually see soft tissue because it tags the blood cells. Very cool. PET scan. This is really cool because it's showing physiology. All these other ones we looked at, the other 5 are just anatomy, but this one, positron emission tomography, is actually looking for glucose uptake in your brain. Like this, you could see somebody who's might be at risk for Alzheimer's or had a stroke, something other horrible in the brain. So you can see how much glucose is being taken in by these brain cells, these neurons, and really checking for metabolism, glucose metabolism specifically. So that's really important. Okay. Any questions about any of this? You feel more comfortable with the feedback mechanisms and what a receptor is, what a control center, a change in stimuli, and then what an effector is. That's all really important.
Professor, yes.
Yeah, what's
you
up?
said, okay, the third, because I'm looking at my, the very last one, you said the PFT is the only one that looks for glucose. That's what you said?
Oh, PET, yeah, the PET scan. Very good question. A PET scan is the only one of those 6 that actually tells physiology, not just anatomy. So they'll all show, like if you have a brain tumor in the brain, we'll talk about the brain. You can do an angiogram to see if the blood vessels are blocked, like in a stroke, or another type of embolism, which is a blood clot that's traveled. You could see that with angiogram. You're just looking at anatomy and a potential for pathophysiology. But a PET scan, a positron emission tomography, and that uses X-ray too, actually, a bit of X-ray, that will show you the uptake of glucose into the cells. So if, let's say, your brain is made of cells called neurons, which we're going to talk a lot about, if the neurons need oxygen, they need glucose to make ATP so they can function, like fire, for memory, for everything. You know, imagine this happens in the hypothalamus. It's a real big problem with the medulla oblongata, but even the parts of our brain that move our muscles or sense input of sensory input, like pain, temperature, touch, tickle, and all those things, speech. So a PET scan could show those neurons actually taking in glucose, of course, insulin would be present. And if you see where it's dark or there's no insulin being taken up in that part of the brain, that means there's a possibility that that brain tissue, those particular neurons, are dead for whatever reason. Usually it's because they don't have enough blood supply. See, look at the neurons behind me. You see that? Isn't that cool? See the little dots? That's the neurotransmitters. So it's kind of like, so those neurons won't be able to release like these neurotransmitters like serotonin or acetylcholine, norepinephrine. Did you ever hear of norepinephrine? You know, those kind of things are important as neurotransmitters. So it's a good way to tell that. Okay. So let me just give you the functions of the skeletal system or skeletal bones really quick before you go to the lab or you actually get some rest for a change, right? 6 hours of class. God bless you all. Okay, so the skeletal system, I just need you to know a couple of things here before you go and while we're recording. Skeletal system, again, what do you think of, if you don't mind, tell me what you think when you hear skeletal system, like for function and reason we have skeletal system.
Protection.
Yeah, for sure. Protection is a great
Structure.
one. What was the other one?
Structure.
Yeah, structure. It gives you your frame and it provides a place for your muscles to attach so you can move for movement, locomotion. Really important. But the point is that first of all, bone. We're talking about bone here. Bone. Why did I put chapter 2? I'm so sorry. Sooner or later, it's going to say 7 on one of these tables. But bone is function, is all those things you're saying. But bone, here's a tough question, but see if you can get this one. I mentioned it before, very early on. What of the 4 tissue types, what is bone?
Connective tissue.
It's connective tissue, right? Oh, it's cells with a matrix. The matrix happens to be a hard matrix, calcified matrix. And what is the function? You told me all these functions. Anything else? I always write functions like this, and we're going to go over this.
Support.
All that thing, all that support, protection, locomotion, attachment for muscles. But don't forget the other 2, and I'm going to tell you 2 before you go. And one of the really important functions of bone is to store minerals, like a bank. And the minerals are in the form, I'm going to write it like this. This is calcium, ionized calcium, lost 2 electrons. And then also you have phosphate too. I'm not going to write, it's too long to write. You have phosphate, calcium and phosphate. So that's another, it's like a bank for blood. To keep blood calcium levels have to be really homeostatic, and you're going to learn that next time. Here's
I'm
the
sorry,
other thing.
Professor. Can you just say what CT stands for? I'm so sorry.
Oh, connective tissue, sorry.
Thank you.
No problem. Always ask. Thank you for asking. Somebody else is probably having the same question. Now, here,
FXN is function, right?
function is calcium storage.
Okay, but the FXN, that's using.
CT is connective tissue is the basic tissue type where bone falls under. And I'm going to go over this many times, so don't worry if you miss it now. It's on the recording anyway.
Okay, all right.
But here's my favorite thing about bone. Look at this word. Where do you see this word? It's ridiculous. I hope I spell it right. It's called hemato, sometimes just hemo, but I like to say hemato because I like syllables. Hematopoiesis. This is a crazy word. Poiesis means to produce. Hemato means blood. So the bone, especially in the red marrow, makes blood cells. How important is that? Come on, right? You think muscles are cool tissue. That's nothing compared to this. Of course, nervous is going to be my favorite, so always remember that. So it makes blood cells. And you're going to learn all about that next week. It's not just that thing we hang up at Halloween, right? That skeletal system. It's more than that. Okay?